Hello, and welcome to ID Talk, answers from an infectious disease expert. I'm Dr. Sean Elliott, a pediatric infectious disease specialist with Tucson Medical Center, professor emeritus of pediatrics at the University of Arizona College of Medicine, and medical director of infectious diseases and immunizations at the Arizona chapter of the American Academy of Pediatrics. This podcast has been created to answer questions from our chapter's members about the COVID-19 pandemic and pretty much everything else infectious disease related. This is the last podcast of 2022. It is December 13th as I speak with you, and wishing everybody a hopefully peaceful season of the holidays, keeping your head above water, nose breathing, etc. Although, as we know, and as we'll be talking about during this podcast, there are a lot of respiratory viruses out there. However, we'll go to the questions. First one, any updates on COVID boosters for children under age 5? What a timely question. In the last several days, first the FDA and then the CDC have officially approved both Moderna and Pfizer's bivalent vaccine for use as boosters to children between 6 months and age 5 or 4. So specifically for the Moderna vaccine, Moderna bivalent vaccine, that has been approved as a booster dose given 2 months after the second primary dose for children 6 months through 5 years, although obviously it's going to be kind of hard to get a booster into a 6-month-old. It'll be easily more like 8 or 9 months of age. But you get the picture. So kids under age 5 are now eligible for that booster, and as noted, it's given 2 months after they've completed the Moderna 2-dose primary series. For Pfizer, the bivalent vaccine can be given as a third dose to those infants from 6 months through 4 years. So basically, not necessarily calling that a booster dose, but as you know, the younger infants are getting a 3-dose series as part of their primary vaccination series. So that third dose now can be given as a bivalent, and then down the road a booster dose for those who completed their primary vaccine series at least 2 months after the third or final dose. So, yay for that. Certainly the bivalent vaccine has been showing much better fit with the Omicron BA5 and 4 strains circulating out there. And as we'll talk about in a second, the current one, the BQ.1s and .1.1s, also seem to be responding or being covered seroprotectively by the bivalent vaccines. So this is a good thing. It allows us to again have a tool which will hopefully be as effective as it seems to have been in older patients and certainly in the adult world against the newest variants of Omicron. So next question, what are the current COVID variants and how well do the bivalent vaccines seem to be holding up? Well, as just noted, so the big ones are B.Q.1 and B.Q.1.1, just to keep things nice and festive. Those are the two principal variants which together are accounting apparently for over 50% of circulating new variants in the country and also in Arizona. The BA5 and the BA4 are also at that level, but they're just under 50%. So not huge changes, although for the BQ.1s and .1.1s, they are again even more infectious, no more virulent, and so patients, including children, seem to mostly be having a upper respiratory type illness. So the sore throat, the congestion, rhinorrhea. In children, certainly the so-called COVID croup seems to be the big deal. But I think, and unfortunately, what we're mostly seeing nowadays is SARS-CoV-2, whatever variant it happens to be, as a co-infection along with some other respiratory virus, most notably RSV, rhino/enterovirus, increasingly influenza, and adenovirus. So that is it's an unfortunate combination because the principal disease that's bringing children into hospital may actually be related to the other respiratory virus. Like RSV has not changed its stripes. It is still a nasty player causing bronchiolitis in older patients and increased oxygen requirements, and it's unclear that steroids or bronchodilators help in those patients. On the other hand, if you add in SARS-CoV-2 or some of the other viruses, they do appear to trigger a reactive airway disease component, and so steroids and bronchodilators may be of benefit. So it's basically a kind of uncharted waters, and certainly this is playing out in real time in the emergency departments where children are coming in with respiratory distress, decreased oxygen saturations, and we're attempting doses of bronchodilators and attempting steroids to see if there might be some benefit. Kind of like the bad/good old days when we were attempting the 3% saline nebulized treatments to see if that made a difference. And I think we're hearing lots of anecdotal yays and nays. So as noted, if you are that that provider who's got a kid in front of you with something resembling respiratory disease and respiratory failure, it's reasonable to try that dose of bronchodilator to see what happens and then respond accordingly. So those are the bivalent vaccines out so those are the variants out there. And as noted, the bivalent vaccines do appear to still be retaining very good efficacy, especially against severe disease and disease requiring hospitalization. That said, the numbers of COVID-19, as expected, are increasing again for the winter months across the country and certainly in Arizona, and they are affecting still a slight, preferentially large number of or under vaccinated people, adults and kids, but unfortunately still also affecting and infecting patients who are vaccinated who may not yet have received the bivalent booster. So sort of the corollary, I guess, is that the bivalent vaccines do appear to be working, just a matter of giving them time and getting them into our patients' arms. The other part of the question then is, how well are the flu vaccines holding up so far? Great question, and unfortunately it is way too early to tell. Over the last several weeks, we've just now started to see influenza A and B make its presence known across the country and in Arizona, and a fair number are probably the H3N2s with some H1N1s in terms of influenza A, but there just are not high enough numbers to evaluate the fit or the match between the current quadrivalent vaccines and the influenza which is circulating. Actually, and ironically, we end up being able to tell how well the fit was past tense after the flu season is over, so sometime next spring, after most of the cases have been typed and compared to the vaccine availability. So at least from the predictive modeling, and this is how it plays out every year, in the part of the world that has previously experienced winters now entering summer months, the vaccines which we're giving here seem to be good fits for the circulating strains in Australia, New Zealand, etc. So keep on giving those vaccines, and we're hoping to keep fingers crossed that they're doing what they're supposed to be in retrospect. Question 3, what is the update about the epidemiology of circulating viral infections? What are we seeing in real time? What is being predicted? So I think we'll start first by talking about RSV, which when last we talked in the podcast was at extreme numbers across the country and still peaking or maybe reaching its peak here in Arizona. That's based on data released to the CDC and other objective reporting organizations, but data released from mandatory reports from commercial laboratories, from hospital and clinical sites, to the state health department and then released to the feds. So Arizona fortunately has a very good reporting mechanism which captures a lot of those positive RSV results and flu and SARS-CoV-2, etc. from commercial providers such as our LabCorps and our Sentinel requests. So those, in addition to other labs sent by hospitals, have equated to a fairly robust reporting mechanism. Keeping in mind that this is still only lab results on those patients who present to medical attention and are tested. It does not obviously capture the vast majority of kids who are sort of sheltering at home with respiratory illness and are going to school and play groups and sporting events and sharing their lovely little gifts of viruses. You may hear my voice, it's a little bit lower because my beloved wife brought home a probable rhinovirus from her students at the school she teaches, and of course I got it. So there you go. That's still happening. So RSV, as of several weeks ago, was peaking and was causing a huge amount of overload in emergency departments, urgent care settings, your clinics, and the hospitals. Arizona was number one in the country, and this is not a good thing, number one in the country for several weeks for lack of availability of inpatient pediatric beds. So at one point, we were 98.6% bed occupancy of all licensed, staffed pediatric beds, ward beds, pediatric ICU beds, etc. That was for the entire state. And certainly at various points in day by day, night by night, there would be a flurry of phone calls trying to find a bed for a patient who's in the emergency department. Fortunately, as with the rest of the country, RSV has peaked and is now coming down. That is being noted here in Arizona as well. Still at fairly high numbers, but they are decreasing on a week-to-week basis. In its place, of course, as mentioned, is our dear friend influenza A and B, and those numbers are now starting to increase. Certainly still at what's called moderate flu levels, although although in other parts of the country they're up to severe levels. Arizona is still in the moderate, but we're climbing. So you can expect to see some more influenza A and B over the next several weeks. Rhino/enterovirus has been a steady stream of joy and badness, and that seems to be slowly tapering down again, perhaps being replaced in its ecological niche by influenza A and B. And we are also starting to see adenovirus come up and raise its ugly head. So patients, especially with multifocal, multilobar pneumonias, which are viral in origin, almost definitely caused by adenovirus. But in that mix, of course, are the secondary bacterial infections caused by pneumococcus and various Haemophilus influenzas. Hopefully not type B, but that's the potential out there as well as our vaccine numbers plummet. So that's the major deal with viral illnesses out there. The upshot of this, of course, is that the emergency departments, urgent care centers are just as busy as they were over the last several weeks, just with perhaps a new mix of those respiratory viruses. In my local hospital, we get weekly microbiology reports, and we're seeing about 25% of sent respiratory panels being positive for a respiratory virus. And so that's 25-30%. That's a fairly high number of positive hits. The mix of those respiratory viruses is almost 50-50 RSV and rhino/enterovirus, but the numbers of influenza and adenovirus are increasing to 10-15% each. And then, of course, we're still seeing some parainfluenzas, 1 and 3 especially, are sort of rounding out the mix. So it is smelling like everybody's worst nightmare of a winter season, with all the viruses sort of correlating their effect at the same time. And yet, fortunately, hopefully, the sheer severe numbers of RSV bronchiolitis may be decreasing a bit, and hopefully the admissions and need for hospitalizations will be decreasing. Okay, and then last question, with the current amoxicillin shortage, what are the best alternative options for treating common infections? So the AAP has released a very nice set of recommendations, which again you can search through the AAP website. Basically, it's saying, first of all, practice good antibiotic stewardship. Well, yeah, don't use antibiotics if they're truly not necessary. And I know we are all practicing that, but that's sort of throwing amoxicillin at the kid with fever and a runny nose, which may be happening still yet, unfortunately, through some of our urgent care centers. That remains a challenge. For those patients that truly have a bacterial infection or strong suspicion for such, and do need entry antibiotics, the recommendations then go, if possible, use a different form of amoxicillin, such as a tablet, and have it be crushed up into applesauce or juice or something like that. Capsules, if they're available and a decent dose, can be opened up and the sprinkles put into some sort of food carrier. Alternatively, there is somewhat more availability of amoxicillin clavulanate, of Augmentin, although again, I would refrain from an antibiotic stewardship approach from using this option unless I needed to. Now, you could easily argue that child with community-acquired pneumonia, which is still yet most likely pneumococcal in origin after you've thought about viruses, still Haemophilus influenza could be a possibility. And if so, most Haemophilus influenza, like 95%, produces a beta-lactamase. So you could actually argue that amoxiclav is a very appropriate empiric antibiotic to cover H. flu plus pneumococcus plus group A strep, and actually plus Staph aureus, which is out there as well. Are those bacteria circulating? Yep, they certainly are. Certainly in my part of the world, we've had several patients with pneumonia followed by effusions, which became loculated and developed into empyemas. So classic association, influenza followed by pneumococcal pneumonia with an empyema, and I think we can anticipate seeing more of those emerge. So using the amoxicillin empirically, if you can find a form which works, is certainly indicated. If not, escalating to amoxicillin clavulanate is the next step. And as those numbers availability also decreases, then the next escalation is going to be an oral cephalosporin. So ceftonir, of course, is the most common one. That is what is FDA approved for treatment of pediatric sinopulmonary infections. A word of caution about using antibiotics such as clindamycin or azithromycin to treat common community-acquired otitis media, pneumonias, mastoiditis, sinusitis. Unfortunately, there is approximately 30% resistance for each of those two antibiotics antibiotics, azithromycin and clindamycin, expressed by pneumococcus, and equal numbers, unfortunately, for group A strep. So those are not magic bullets at all, even though when azithromycin was first released, we all looked at that as sort of the holy grail of, wow, it's once a day, it's 5 days, it's easy, it's fantastic. But there were a fair number of treatment failures back in the 90s, and those continue today, as evidenced by antibiotic resistance patterns. So, how to escalate? So amoxicillin, if you can get it, a different form of amoxicillin, if you can get that, cutting it up, chopping it up, sprinkling it, etc. And then if amoxicillin clavulanate, if the amoxicillins are not a possibility, and then ultimately going to ceftonir. One additional option for those kids with routine acute otitis media, not complicated, first time, would be to consider that single dose of intramuscular ceftriaxone in the office. If you're able to do that, that is an option. It's painful, but it does sort of obviate the need or reduce the need for oral dosing of amoxicillin. So that's kind of where we stand right now. Brief updates about what else is out there. I think those who follow the news are aware that Ohio currently is in the middle of a measles outbreak being the true word. 58 cases as last reported. There are more out there, and the CDC is currently doing contact investigation to identify who else is out there. Certainly remains the concern of polio in the East Coast and in those parts of the country where polio vaccine coverage is under herd immunity levels, such as 90% or so, and other vaccine preventable diseases are still out there as well. So as our vaccine coverage rates continue to be a major source of concern in Arizona, for example, there are communities, there are school districts that unfortunately are very permissive of personal and religious exemptions, such that vaccine coverage rates with routine pediatric vaccines is under 80%, certainly under 86%. So Arizona, unfortunately, once again, not a good thing. We're in the top 5 states in the country for decreased rates of vaccine coverage with pediatric routine vaccines. So the likelihood of a measles case, of a mumps case, unfortunately is not zero. And the likelihood of a pertussis outbreak is not zero. And the likelihood of polio coming here, also not zero. So anything and everything that we can do to get our patients into the practice, social media outreach, certainly the chapter has been trying to partner with school districts and social media outreach as well, just to try and get patients back to the medical home, to the offices, so that we can have those conversations about updating the vaccines. So that, I imagine, is going to be our challenge, our windmill to tilt at for the next easily 5 to 10 years, as we hopefully recover from the damage done to vaccine coverage by attacks on science and by the pandemic. That's not a very hopeful message to leave you with, so I apologize. Into the plus side, I think we are at certainly a plateau with respiratory viruses, and our kids are not, so far, knock on wood, coming in with any major surprises with infectious diseases. So these are all manageable things. We know how to do this. We certainly know how to administer respiratory treatments and evaluate for bacterial secondary infections and or primary infections. We know how to do these things. It's just a matter of buckling up and gritting our teeth and doing it and getting through the season, and there is an end in sight, absolutely. So with that, thank you for listening to ID Talk. Arizona AAP members can submit questions for future episodes to covid@azaap.org. The Arizona AAP chapter would like to acknowledge the generous support of this podcast by the Arizona Department of Health Services through the Title V Maternal and Child Health Services Block Grant funding. For more information and resources related to COVID-19 in Arizona, or to learn how to become a member, please visit us at azaap.org. Meanwhile, my personal wishes of a peaceful holiday season, Merry Christmas, Happy